Good afternoon. Thank you again. So hopefully everyone's ready for round two. If you notice, I changed the title to how I do it, embolization, vascular malformations, and I didn't use AVM here. This goes back to my point earlier about nomenclature. So I'm going to walk you through the whole slew of vascular malformation treatment, the whole embolotherapeutic landscape, not sticking strictly to AVMs. So I think that's an important point. So for those of you who didn't attend the earlier talk, I think it's important to understand that vascular anomalies, which is the broad term, is a very broad clinical spectrum. It has can affect any organ at any age. Each of these things, based on their specific classification, they're distinct clinical entities and have very idiosyncratic natural history, hemodynamic profile, and as a result, the treatment options vary. So it's very important what we call these things, and we should not be using haphazard terms like AVMs or hemangioma to label these things. We have to be very specific. The ISFA classification is the clinical classification that I like to use. It's based on the pioneering work of John Mulliken. Remember that vascular tumors are a completely separate entity. They can also have certain embolotherapeutic options, but we're focusing on vascular malformations here, and that can then be broken down into slow flow malformations and high flow malformations, which we're going to talk about individually, and each of those has a very unique and idiosyncratic and tailored embolotherapeutic portfolio of treatment options. Low flow malformations, these are your venous and lymphatic malformations. Remember that these can be either sporadic or syndromic. In other words, they can happen on its own. So someone can have an isolated either capillary malformation or lymphatic malformation or venous malformation, or can they be combined? But remember that these are sporadic, or they can be part of a broader syndrome. Classically, syndromes associated with low flow vascular malformations are Klippel-Trenaunay syndrome, Clove syndrome, Maffucci, etc. So I think it's very important to understand which syndrome features what type of malformation. Again, emphasizing the importance of nomenclature and not using haphazard terminology, because you're going to go down a specific therapeutic platform and portfolio if you have a specific diagnosis. Lymphatic malformations are errors in lymphangiogenesis. They can be macrocystic, microcystic, or mixed. They tend to be more prevalent in the head and neck, and they can lead to infection, bleeding, and mass effects. So treatment is always indicated once you identify a lymphatic malformation. Again, this is what it looks like, and remember, the most important thing with lymphatic malformations, this is a water-filled balloon. It's a water balloon. You're trying to puncture this balloon, suck the fluid out, get the balloon to collapse, right? So as to that the walls are opposing one another. And once these walls are opposing one another, you want to introduce some sort of an irritant, a sclerosant, so that causes an inflammatory reaction and prevents this water balloon from refilling. Okay, so drainage alone is not going to be enough. You have to get excellent collapse. And the key to successful treatment of a lymphatic malformation is going to be adequate drainage or collapse, if you will. Now, if you notice that here, you're going to see a lot of septations and lobulations, and these septations and lobulations can sometimes prevent you from getting that water balloon to completely collapse onto itself. It is very important that these septations and lobulations are broken down, or you may have to access that cystic structure on a different side of this, the septation or the lobulation, so as to get appropriate breakdown and so as to get appropriate drainage. You want that good sac collapse, which then you can interrogate via lymphangiogram. So this is a giant case of a lymphatic malformation, intra-abdominal. This is the bladder being compressed by this big multicystic structure. You can see that we were able to puncture it percutaneously, and because of the sheer size of it, once we did the lymphangiogram, we see that there is a contiguous structure in place that we can interrogate angiographically. We were then able to draw out the contrast and then introduce our sclerosant. And you can see this sort of milky fluid that's being drained. And I like to send those for gram stain, culture, cell count, and cytology. Excuse me. Again, a whole slew of embolotherapeutic options exist. Remember, these are all off-label. There is no FDA-approved or sort of globally approved therapeutic option, although we're working on it in the United States at my center. Doxycycline tends to be the one that's used most often. Remember, this is not being used because of its antibiotic properties, but it's being used because of its anti-matrix metalloproteinase and anti-vascular endothelial growth factors. Surgical excision, by and large, I tend to reserve it or recommend it as an adjunctive modality to remove any residual scar tissue or soft tissue structures that may be left in place. I would not advise directly proceeding to surgical excision because oftentimes that cystic wall can get violated, there can be leakage of fluid, and you can wind up with recurrence and all kinds of infectious complications. For venous malformations, remember that these are most common. They're sort of these soft, spongy, compressible masses. Pain is very common with them. Remember that these can be associated, especially perioperatively, especially with good embolization, it can be associated with a term called localized intravascular coagulopathy. So I think perioperative evaluation with colleagues in hematology looking specifically at the coagulation profile, von Willebrand's factor, D dimers and fibrinogen levels are critical, and these are going to determine the need for perioperative anticoagulation if the patient is not already on it. And remember that hemorrhagic complications with venous malformations are incredibly rare. Remember, these are low flow. So unlike arteriovenous malformations, they're not going to bleed severely on you, by and large. Contrast-enhanced MRI and not MR venogram or MR angiogram is really the way to go. This is the hallmark feature of these lesions on cross-sectional imaging, and they can be readily detected on duplex as well. The mainstay of treatment for venous malformations is not surgical excision, but rather a term that I like to use, direct stick embolization. This involves image-guided identification of the malformation. You can use certain maneuvers such as insufflating a tourniquet sort of downstream or more centrally so as to augment the malformation, and also to help prevent sclerosant escape into the systemic circulation or deep veins. I often also like to use an intravenous catheter where you see where this bandage is, and through this intravenous catheter I like to run heparinized saline through the deep venous system, and what that does is if there is a slight chance of sclerosant escape into the systemic circulation, you wash it out with your heparinized saline. A very nice article in the Journal of Vascular Surgery talking about my protocol for it. There was some very interesting discussion and editorial commentaries sort of back and forth in terms of what options to sort of use. So I would recommend you to look that up. It makes for a great topic of discussion. As far as the options for treatment, and again, the mainstay agents that are used are detergent-like compounds like sodium tetradecyl sulfate and polydocanol. These are anionic surfactants that cause a very intense inflammatory reaction within the endothelial cells, and that inflammation then begets thrombosis and fibrosis. There are certainly other more potent options such as ethanol. This was championed by Dr. Wayne Yakes, who has really spoken on this globally and probably has the largest experience in the world using ethanol. I tend to use a steer clear of ethanol because, in my humble opinion, the side effect profile of ethanol does not justify its use for these relatively benign lesions by and large. This is what the direct stick embolization of venous malformation looks like. You can see the correlation with MRI. You can see that a simple puncture can delineate the outline and the contour of the malformation extremely well. Remember that these can either be sort of these very focal lesions, but sometimes a simple puncture can delineate the entire contour and outline of what seems to be just the tip of the iceberg, that there is a much deeper and much more extensive venous malformation. Once inside, then you've delineated your venous malformation venographically. You can then proceed with introduction of your embolotherapeutic agent of choice. Again, there are a number of those exist. And sometimes you may have to use more sophisticated imaging such as spiral CT to gain access into difficult reach structures, but this is certainly feasible. So, this sort of retropharyngeal venous malformation that looks almost impossible to reach, you do not necessarily need these huge surgical approaches. Very clever, simple needle puncture can treat this problem very easily, and you can get inside of these with the help of some colleagues. Sometimes we have to use endoscopic techniques, laparoscopic techniques. Again, depending on what body part, you may have to collaborate with folks, surgical specialties from other fields, and so as to allow them to provide you a window through which you can then go ahead and proceed with direct stick embolization. Again, multiple case reports and technical notes that I've published on it. Again, encourage people to take a look at that if they're interested. Just a quick note delineating that over the last 5 to 10 years, we have outlined, essentially, we have a genetic roadmap for the molecular basis of these vascular malformations. We now know that, for example, for our low flow malformations, these somatic gain of function mutations in the mTOR pathway are implicated and are involved, and so this creates an entire new opportunity for embolotherapeutic portfolio. For me, based on these sort of insights, I've gone ahead and started my company called Targeted Therapeutics in the United States, and this revolves around direct intralesional delivery of biomolecularly active agents into the malformation, and we are trying to essentially standardize the embolotherapeutic portfolio and steer clear and steer away from these compounds such as detergent-like compounds or ethanol, which have sort of grandfathered their way into the treatment armamentarium but don't necessarily represent a sort of a standard of care. So this has become my own personal go-to mechanism with our sort of international patent compound. I no longer use any of the other agents as well, and the results of essentially more than 20 patients treated to date, both clinically and imaging-wise, has been quite remarkable. We're going to talk about now the meat and potatoes of the talk, which is the high-flow malformations. These are notoriously difficult to treat. We can come across as incredibly vicious and problematic. Again, remember that these also can either be sporadic, in other words, happening by themselves, and they can either be just simple arteriovenous fistulae or malformations, or they can be syndromic. The syndromic cases associated with AVMs are syndromes such as Parkes-Weber syndrome, Rondo-Osler-Weber syndrome, also known as hereditary hemorrhagic telangiectasias. Proteus syndrome can be associated with high-flow malformations, so on and so forth. So again, diagnosis is going to be critical in this, and as is nomenclature. Remember that AVMs represent pathologic connections between an artery and a vein anywhere upstream of capillary level, okay? And this causes primarily, first and foremost, venous hypertension. So let's not focus about the importance of the venous outflow as a potential target of embolotherapy and a means to halt or slow down the growth. And it just depends on what the malformation looks like. This is a good representation of a variety of different configurations of malformations. Classically, they tend to involve this nidus. This nidus is a conglomerate of blood vessels that are poorly differentiated, that have neither an arterial nor a venous designation. Sometimes the nidus can look like these direct fistulous connections where the vein draining the AVMs can become aneurysmal, and I have pictures of a case that outlines that as well. On MRI, again, contrast-enhanced MRI, you see these flow voids, and the flow voids represent essentially the fast flow shunts that exist within the nidus of the arteriovenous malformation. Again, I'd like to emphasize that the key to successful AVM treatment is penetration of the nidus that connects the arteries to the veins pathologically. Anything outside of the nidus via coil embolization of the feeding arteries or the draining veins, or surgical ligation or clipping or anything else that does not penetrate the nidus is a futile endeavor and is a waste of time and is going to make your life much worse. You may get a beautiful initial angiographic result and the patient may feel great, but I guarantee you that AVM is going to come back, and it's going to come back with a vengeance, and now you're in a much more difficult position than you were before, and covered stents and things like that just do not work. There must be penetration of the nidus, and the key to nidal penetration is going to be feeling comfortable with a coaxial microcatheter-based system. You have to be very comfortable floating a microcatheter, maneuvering a microcatheter, and getting the microcatheter as close as possible to the nidus of this AVM. And once there, the hallmark or the mainstay of AVM embolotherapy has been the use of liquid embolic agents. Again, ethanol has been used and highly promoted by Dr. Yates. I tend to steer clear from it and advise against its use because there have been certainly reports of death and central cardiopulmonary toxicity. Ethanol is very potent. It denatures proteins. It works very well because of its protein denaturing properties by destruction of endothelial cells, but that potency can carry over and cause complications as well, including adjacent nerve damage and some of the lethal complications that have been reported with the use of ethanol. So you must be incredibly comfortable with ethanol, very comfortable with advanced endovascular super selective catheterization, and even then I would advise against using it. I tend to use liquid embolic agents such as N-butyl cyanoacrylate and onyx. These are polymerizing agents, one glue being rapidly polymerizing via a exothermic reaction, and onyx being a little bit more slowly polymerizing. And I'll talk a little bit about how coils actually, certain profile coils have now sort of replaced these liquid embolic agents in my own personal practice. Wayne Yates has a very nice and clinically applicable classification system for AVMs. Remember that this is a different classification scheme than what I talked about earlier, in other words, the ISFA classification. This is a classification scheme that tells you what type of arteriovenous malformation you're dealing with so as to dictate your best approach. There are sort of Yates type 1, which is a direct fistulous connection, something like this, for example. There's a Yates type 2, which is a 2A and 2B. The 2A is the one that classically involves a nidus, something like this, which is that low pressure sump that sucks blood and recruits arterial feeders and venous drainers. The 2B AVM tends to be the ones that have a nidus, but that nidus has an aneurysmal degeneration of the vein. And under those circumstances, the nidus is, the venous outflow, the immediate venous outflow is involved in the nidus. So if transarterial route is not an option or is not a feasible option, embolizing the venous drainers can be a very useful adjunct via a retrograde manner or via direct puncture. And then you have 3A and 3B where there's just more variety in the way these veins are aneurysmal, and type 4 AVMs are the ones that are just completely, essentially all you see is a nidus. And we have pictures of all these that we can kind of sort of talk about. These are sort of classic Yates 2A arteriovenous malformations. These are direct connections between multiple feeding arteries. For example, in this case, this is coming from the terminal branches of the perineal artery feeding this giant nidus and with prompt venous drainage. And you can see that essentially the onyx that I injected into this was able to penetrate and completely plug the nidus. And we can see very good nidal penetration by using certain liquid embolic agents, certain polymerizing agents. On the far right here, we see a massive nidus of a Yates 2A arteriovenous malformation. Again, onyx was used here, preserving the artery to the digital branches, which is critical, but then plugging the nidus to help slow down the vicious shunt that it can exist. I think it's very important that sometimes, right, you have arterial feeders and you have venous drainers, and you can super selectively microcatheterize and get into the nidus via the transarterial route, or sometimes you can go retrograde through the vein. We'll talk about that. But under certain circumstances, the nidus may be very difficult to access, or it may be so large that you don't even know where to start. You would have to embolize for 24 hours to be able to get this whole thing to sort of slow down. Under those circumstances, I've published my experience with direct stick embolization of the nidus. So you perform an angiogram, you delineate where the nidus is located, and based on that delineation, you can then use ultrasound or direct blind puncture and access the malformation. For example, this was a patient with Parks-Weber syndrome of the gluteal region. I was able to outline this really broad nidus that existed throughout the gluteal region that was leading to ulcerations, as you can see here. And with just a simple needle puncture, I was able to get inside the malformation and use onyx directly into the needle and was able to puncture the malformation. This is basically the onyx cast that is deposited into the nidus of the AVM. So let's not forget about the use of direct stick embolization for embolization of the nidus, okay? This is a situation of a very large AVM of the hand. The patient was right hand dominant, postpartum patient. Very nice woman. A plastic surgeon wanted to basically do a partial amputation. She was quite devastated. Angiographically, we were able to identify the very large vicious shunt. You can see essentially almost no digital arterial flow based on the shunt that existed. You can see very large draining veins that are draining this very large nidus. So a sort of multimodal approach was used. I first went transarterial. I was able to inject a cast of onyx. There was a second part of the nidus that I accessed via direct puncture. And then as a third option, retrograde, I went through the draining vein and was able to place some coils to basically halt the shunt through the AVM. So a single session of treatment, and we were able to get this kind of result. And the patient basically we were able to save the hand and the livelihood of this patient. So again, this has been published. I encourage you to kind of take a look at it. But the point is that please do not be afraid to use multiple different approaches. So if one doesn't necessarily work, it doesn't mean that the others might not. So don't give up. These things can look very intimidating. They can look very scary. But if you do a very detailed angiographic run and understand the hemodynamic profile, and you have these tools within your armamentarium, you can tackle these things one at a time, but just make sure that you are sort of comfortable with this whole portfolio of therapeutic options. When I talk about floating a microcatheter, this is what I'm talking about. So in this case, you could see, for example, what kind of twists and turns we have to take and what kind of This is a 5 French Berenstein catheter in the terminal branches of the radial artery with this microcatheter advanced with an 014 wire. And you can see that this is what I'm talking about in terms of nidal access. If we were to plug this anything proximally, this would be a futile endeavor. This is what we need to tackle, folks. This is what needs to go away in order for this AVM to have more definitive eradication. And so in order for us to get to this place, this is the sort of level of microcatheterization that we need to be able to accomplish. Besides this, anything else is simply futile, and you've done more harm to the patient than good, and you've done more harm to the future surgeon or interventionalist who's going to have to come in, and now you have eliminated for him or her that direct transarterial route for approach. Okay, so this would be a case where it would be quite amenable, for example, to transarterial embolization followed by, now that I've outlined this in the hand, I can then proceed with direct puncture embolization and using entities such as glue and perhaps even onyx. I talked a little bit before about coils. By and large, in my own personal practice, packing coils or that are mechanically detachable, delivered through a microcatheter, have largely replaced these liquid embolic agents. The liquid embolic agents can be expensive. They can be cumbersome to use. You basically have no control. Once the liquid exists, the microcatheter, you basically have no control. There's no retrievability, right? And there's obviously a potential for non-target embolization and all kinds of issues associated with it. Not to mention that every time you sort of inject your glue or your onyx, you have to replace your microcatheter and you have to re-access the malformation. So that can be quite time consuming, it can be cumbersome. There's a risk of the microcatheter tip getting stuck to the substance of the liquid embolic agent that you've injected. Whereas with coils, these are completely inert, obviously. They are detachable. In other words, you can advance the coil, you can retrieve it when you don't feel like the position is nice, or if you feel like there's a risk of non-target embolization or premature shunting. So in my own personal practice, I've had remarkable success using what I like to call liquid metal. This is a case of a sort of subscapular arteriovenous malformation. You can see a 5 French Berenstein catheter into the thoracodorsal artery, microcatheter all the way down, and we can get very good nidal penetration. And by advancing the coils, you can see that just like onyx and glue, they take a very nice cast and they form and conform themselves very nicely to the nidus of the AVM. And they're quite durable, so you don't have to worry about recanalization. Here's a case of a chin AVM, another one of the lower lip and the chin area, all of them treated with coil embolization, followed by, in this particular case, surgical excision for cosmetic reasons. But obviously, we have to devascularize the malformation, so there's no lethal hemorrhagic complication going directly with surgical excision. A very recent case, painful arteriovenous malformation of the foot in a very young lady, active young lady. You could see that the entire thing was used to treat completely with coils. No glue whatsoever, and I rarely use this term, and I used to rarely use the term cure. I was very humble about it because we felt like we're not essentially curing, we're trying to basically improve the quality of life of the patient. But in this particular case, I can say that this AVM is cured. These coils are not going to go anywhere. The thing is completely devascularized. I was able to penetrate the nidus of the AVM with the coils. The lesion is cured and is not going to cause this patient any problem. And this is just with a single session. So there's a tremendous role for the proper use of coils, and I think you have to be very versatile with knowing which coils to use and which ones not. Very interesting case here. This is a arteriovenous malformation of the tongue, and I know you can't sort of tell like this, but this is a 5-French catheter placed in the common carotid artery. You could see branches of the facial and lingual artery feeding this AVM nidus. The nidus presented itself in the tongue. On a sort of more sagittal view, selecting the external carotid artery specifically, you can see the terminal branches of the facial lingual arteries feeding this nidus. So advanced the 5-French catheter into the terminal branches of the facial artery, floated a microcatheter, and was able to, you can see with the coils, we're able to get them into the nidus. So as you can see here, the nidus is penetrated with the coils, and the main trunk of the feeding artery, right, it's plugged. Then what I did was I then externalized the patient's tongue. You can actually put just a silk suture, pull the tongue out, and then I placed a needle directly into the tongue, and I injected this cast of glue. So what you see here is a direct stick embolization of the tongue arteriovenous malformation with glue, and the feeding artery has been taken out. This is another case where I would consider this case cured. This is not going to be something that's going to be problematic. And then I refer the patient to a otolaryngologist who is going to do a surgery on the tongue and do some soft tissue reapproximation to remove that sort of cast of devascularized tissue that has been left behind and is causing the patient issues with chewing, so on and so forth. So this is a multimodal approach to treatment of an AVM, and I think it's important to maintain good collaborative relationships and designate sort of key figures who are interested in other specialties to help you out. I wouldn't feel comfortable as a vascular surgeon operating on the tongue and doing soft tissue reconstruction. I think it's important to find a colleague who is comfortable and understands this pathophysiology and knows what they're dealing with in this particular area as well. This mess that you see here that scared a lot of interventional radiologists for this morbidly obese patient, COPD, on multiple antihypertensive medications. She was placed on she was oxygen dependent and was placed on the heart transplant list because of high output cardiac failure from the arteriovenous malformation. You can see on aortography, folks, this is like after maybe 1 second or 1.5 seconds of the digital subtraction angiography. I don't even see the aorta anymore. It's the vena cava and the iliac veins. The thing is shunting so rapidly. It's such a vicious shunt that is all going into the AVM nidus. And all of this is going back up towards the heart and causing high output cardiac failure. This patient couldn't walk. She couldn't breathe. She was utterly miserable. Was sent to an interventional radiologist, multiple interrogations, and they said this is too high risk, nothing to do. We're going to embolize and we're going to cause problems. And that basically she needs to be sent to hospice. Well, don't allow the pictures to scare you. It looks very scary. It looks like a mess. You wouldn't even know where to go. But I think taking your time and doing deliberate, selective and super selective angiogram, identifying exactly what's going on and what's shunting into what, and doing it in stages. There's nothing wrong with doing this in stages, right? If you do it properly and safely, you can do 4, 5, 6, 7, 8, 9, 10 sessions of embolization, but doing it in stages so as to minimize the toll on yourself and the patient as well. And each time you've sort of, what I like to do, you've pruned the malformation one by one, slowly by slowly. This was another case that I did not use any liquid embolic agents, strictly used coils, and you can see the branches of the internal iliac artery on the left side that are slowly starting to fill. So as opposed to the picture on the right where it's just the hodgepodge, it's a mess, this one is starting to make a little bit more sense. It's starting to look a little bit more approachable. And here you can start to use a very detailed and deliberate selective use of coils, which you can see here, and you can see that the extent of nidal penetration that I was able to get slowly shutting down the malformation. Remember, you don't want angiographic perfection, but you want improvement. I want to get this patient off oxygen. I want to get her off the antihypertensive medications as much as possible. And I want to get her a quality of life where she can move and function without feeling completely debilitated. And I want to get her off the heart transplant list. And I was able to do that for 3 sessions of embolization. Okay? Again, I want to show the coils, and I want to emphasize.
If you could wind up the
Sure.
this one as we're running off the time.
Coils work very nicely here. You can see the before and after, the kind of pictures that you're able to accomplish. Case of an Osler-Weber-Rondo syndrome, using a combination of retrograde venous coil embolization, onyx embolization, and the transarterial route, angiographic delineation. This is the AVM of the lower lip that I showed before. Using a combination of coils and direct stick embolization, we're able to get these kinds of results. And this is a 10 centimeter venous aneurysm of a massive pelvic AVM that had been ligated. So I had no, the internal iliac artery branch that was feeding the AVM was ligated. So I had to go through retrograde through the venous route. And what you see here is a total of 110 coils placed in the venous aneurysm to halt the flow, along with multiple coils into arterial feeders. And this was another case that I would call cured in this impending rupture 10 centimeter venous aneurysm draining an AVM. And these are the angiographic pictures before and after. So you can see this big ball of coils that is basically completely stopping the flow. So I'll stop there, and thank you for your time. Apologize for going over. Happy to answer any questions for you.